So how quickly do I determine whether a patient is steroid refractory or steroid dependent? I generally wait 3 to 5 days, and if patients have persistent symptoms after 3 to 5 days of therapy with high-dose steroids, then I would classify them as being steroid refractory. How often in my experience is acute GvHD refractory to corticosteroids? I would say about a third of the time, so approximately 30% of patients develop steroid refractory GvHD. This is based on data from a randomized trial comparing 2 to 5 milligrams per kilogram of steroid therapy as initial treatment for acute graft-versus-host disease. That trial showed no benefit with giving the 5 milligram per kilogram dose, and that's why the 2 milligram per kilogram dose is what we consider to be more of a standard upfront steroid dose. But in that trial, the arms showed about a 30% refractory rate to steroids for treatment of acute GvHD. What is the trigger to start second-line therapy? Primarily persistent symptoms. And that can be very difficult, honestly, and that gets into the art of medicine. So the rash may not be completely resolved, but it should, in my opinion, be changing colors. So it shifts from being more of a bright red, intense color to more of a port wine color that's more deep purple. And the itching also rapidly improves if a patient is responding. In regards to the GI tract, the diarrhea should definitely be improving. The increased stool frequency may not be completely gone, but the consistency of the stools should be shifting from liquid to more of a solid base, so more of a mushy base. Certainly there should not be any more GI tract bleeding, and there should not be any more completely undigested food. And then the abdominal cramping, abdominal pain should be improved and resolved. But admittedly, these are somewhat subjective, and it does get into the art of medicine, and it is one of the more difficult things that I have to do when following a patient. Is it better to react sooner than wait? In my opinion, yes. If patients have untreated acute GvHD, that is very bad, and particularly if patients have persistent symptoms after steroid therapy. What happens with GvHD is that you get cellular mediated damage of the GI tract, the skin, and the liver. That releases antigens into the circulatory system, which then upregulates continued cytotoxic T cell response. So in essence, there's an auto-amplification loop that's built into graft-versus-host disease. So you need to get on top of that inflammatory cascade as soon as possible. And if you don't stop the ongoing T cell mediated damage, then patients, of course, can die from graft-versus-host disease. And we see this most clearly when patients have GI tract symptoms. So if there's any question whether or not the patient is having continued symptoms, it's better to err on over-treating than under-treating. Our nurses are on the front line, and they generally get the first telephone calls when a patient develops acute GvHD. All patients who undergo transplant at our center are told multiple times what the symptoms of acute GvHD are: skin rash, nausea, vomiting, diarrhea, abdominal pain, liver function abnormalities, and we monitor patients very closely for any of these symptoms. We're open 24 hours a day, every day, and if patients develop symptoms over the weekend, there's always a triage system that's built in. So there's no patient who develops GvHD symptoms that should wait, even if it's in the middle of the night. So that's an important message to send to the patients. And then in regards to the pharmacists, they play an important role because we all work together to make sure that patients have therapeutic drug levels. So many of the medications that we give for treating GvHD, such as tacrolimus and sirolimus, we have targeted drug levels. So we work with the pharmacist to make sure that the patient is taking the correct dose, whether they're receiving that for prevention or for treatment of acute GvHD. And then, as I mentioned, the nurses are really on the front line. In the hospital setting, they round with us every day with the patients. They're the ones who actually are tracking the stool output. So they have the best input into how much stool a patient is actually having, what the consistency of the stools are, if there's undigested food, those types of things. And in each patient's room, we have a big meeting with the nursing staff, with the pharmacist, with the APP support, the residents, and the attending physician, all giving their input at the same time. So it is really a team approach to ensure that the patients have the best outcome. And it's important to get the help of the patients, because if they don't tell us about their symptoms or they let their symptoms go, then of course we don't start treatment on time and patients can have a negative outcome. What is the incidence of acute GvHD after transplant in the patient population at our center? That is variable depending on donor status and depending on GvHD prophylaxis. But just taking, the most common approaches, we generally give a TAC methotrexate GvHD prophylaxis for patients who have matched sibling donors and matched unrelated donors. For the matched sibling donors, our incidence of developing grade 2 to 4 acute GvHD is approximately 40%. And for matched unrelated donors, our incidence of developing grade 2 to 4 acute GvHD is approximately 60%. What are the expectations surrounding treatment and supportive care? Our expectation is to involve the patient so that they let us know as soon as any symptoms may develop. We do have clinical trials, of course, that are in place for patients who develop acute GvHD. And if they do, our primary goal is to try to enroll them into one of these clinical trials with the effort to improve overall outcomes. If they're not eligible for a clinical trial, then our initial treatment for acute GvHD would typically be sirolimus or steroid therapy. The REACH-2 trial was a pivotal phase 3 trial that compared ruxolitinib, given at 10 milligrams twice daily, to investigator's choice for patients who develop steroid-refractory acute graft-versus-host disease. It was a very important study because it's one of the few studies that we have that actually shows a benefit for treating steroid-refractory acute GvHD. The patients were randomized to either receive ruxolitinib or investigator choice. And for investigator choice, there were several different options. One of those, of course, was HEG therapy. Another option was extracorporeal photopheresis. But regardless of whatever the physician chose, ruxolitinib essentially won out and had better overall response rates. For patients who develop steroid-refractory acute GvHD based on the REACH-2 trial, I think ruxolitinib should be considered the standard approach. Of course, the option of enrolling patients into a clinical trial is still there, but that would be the big change. So instead of going for extracorporeal photopheresis or for HEG therapy, we would generally start patients on ruxolitinib or enroll them into a clinical trial if they are eligible.